Okay, today I was going through some MCQs and I came across a question on eosinophilic esophagitis, and I thought it would be useful to just revise this topic for you in 10 minutes or so. This is the case that a patient I looked after some years ago, a 22-year-old chap referred for assessment of eosinophilic esophagitis. The diagnosis has pretty well already been made, but let's go through it. Atopic background, he's had allergic rhinitis since childhood, both seasonal and triggered by dust exposure, consistent with house dust mite. He had childhood atopic dermatitis, which then got better, which is what happens in many cases, as you know. No history of asthma. He did, however, have kiwi fruit allergy with clinical symptoms on exposure and was positive on skin testing. And the skin testing that I did in my practice showed, again, confirmed house dust mite sensitivity. I think we'll come back to that shortly. He takes occasional antihistamines, nasal sprays for the hay fever, works or currently studying as a student. Now, he came to the attention of the gastroenterologist when he got sudden onset right lower quadrant pain, suspected of an acute abdomen, consistent with a CRP of 154. But the symptoms seemed to settle quite spontaneously. He came to an endoscopy later on, and perhaps somewhat surprisingly showed severe eosinophilic esophagitis. He had a bit of reflux symptoms, but nothing dramatic. He also had colonic eosinophilia, which was a little bit unusual. Biopsy came back confirming marked eosinophilia in the biopsy, quite severe erosive disease, and there was also low lactase levels in the stomach. Make of that whatever you wish. As I mentioned, skin tests in my rooms were positive for house dust mite and grass pollens, negative for the usual foods as expected, and strongly positive for kiwi fruit, consistent with the history. So the gastroenterologist had already put him on pantoprazole. As I mentioned, he had fairly minimal symptoms to start with, but from a perspective of possible food triggers, notwithstanding the negative skin tests, and we'll come back to that, we did an empirical milk elimination diet because it's a very frequent trigger of this condition. And indeed, he responded very well to that with a repeat endoscopy after 4 to 8 weeks showing resolution. The plan was that if it hadn't shown resolution, we'd go on to do a proper elimination diet and or consider topical steroids such as budesonide. Just on the off chance, because I'm an immunologist, we checked the anchor to look for this eosinophilic infiltration of the colon, and that was negative, and he of course showed no other manifestations of systemic vasculitis. So as I mentioned, milk-free diet alone seemed to fix him, at least endoscopically. He stopped his PPI, he had minimal symptoms thereafter, but he didn't have much to speak of beforehand, and the long-term plan was, unfortunately, you're going to have to maintain dairy-free for the foreseeable future with the help of the local dietitian. So this case shows the association between eosinophilic esophagitis and atopic disease. It shows that the skin testing is absolutely unpredictive of triggers, but it can demonstrate the atopic state based on positive skin prick testing to house dust mite, grasses, and kiwi fruit here. Empirical elimination is a reasonable first step, and milk is such a common trigger, and it's relatively easy to eliminate just on the possibility that that's your culprit. Histological response is all we could rely on here because of his relative lack of symptoms. But if he had symptoms that were ongoing, or the repeat biopsy had shown ongoing severe disease, the aim would be to go through the usual approach of managing this condition with complete 6-food elimination plus or minus topical steroids, as I've mentioned. Okay, so let's quickly talk about eosinophilic esophagitis. Thanks to ChatGPT for generating that. And believe it or don't believe it, I probably don't believe it, but it looks nice. Well done. Eosinophilic esophagitis falls within the atopic spectrum, and it's interesting because it is a cellular response to a food allergen. So we're used to acute food allergy, food anaphylaxis like peanuts and shellfish, which can trigger systemic anaphylaxis via the IgE that is produced by the Th2 cells. But in this condition, we're dealing with a Th2 response that is cellular, not related to IgE. And that's why the skin tests aren't very useful in predicting what the person may be reacting to. So the Th2 cellular response results in eosinophilic infiltration and therefore esophageal symptoms, pretty much like reflux symptoms. Sometimes late you might get dysphagia, and then a trial of PPI is performed. Sometimes this actually works, and the diagnosis may never be made, but often it doesn't. The patient comes to endoscopy, and it shows the eosinophilia over the diagnostic threshold of 15 cells per high power field. Epidemiology, mostly male, funnily enough. Prevalence seems to increase with age, sort of middle age is typical. There's often a strong family history, particularly of atopy, but you're used to that in atopic disorders, right? And they present with GORD-like symptoms. They often find it very difficult to identify a trigger because these are T-cell mediated and therefore not acutely related to any ingestion. Typical triggers are milk, wheat, eggs, soy, nuts, and fish. As I mentioned, skin tests can't help you with this. And there are a few cases where oral desensitization, like sublingual desensitization, can trigger this type of response in the esophagus. That sort of makes sense. It's a little bit artificial. We don't normally eat pollen. I don't. But patients on oral desensitization may develop this complication. Okay, the endoscopy, I'm not an endoscopist, thank God, but basically endoscopy shows some typical findings. It's often done after initial PPI therapy, just because that usually works in the majority of patients with these types of symptoms. The lesions may not be continuous, so multiple biopsies are usually performed, and it may require more than one endoscopy. So sometimes the appearances are normal and the histology comes back suggestive, but usually you get edema through the loss of vascular pattern, wide exudates reflecting eosinophilic microabscesses, longitudinal furrows, and often described as a crepe paper mucosa with fragility and mucosal tears. And late, untreated, you get the sort of chronic fibrotic effects with trachealization, with rings around the esophagus, a narrow caliber esophagus, and focal strictures which may require mechanical intervention. Histology, again, just to note that the histology is dominated by eosinophilia and epithelial remodeling, often with fibrosis. There's this diagnostic threshold which the histologists will look after for you, and you can find microabscesses as well as degranulation occurring within that biopsy. A few other changes that I've mentioned here for completeness. Of course, I'm mostly interested in the pathogenesis. That's where that's my main interest in immunology. And so let's work through this. There's a genetic predisposition like there is with many atopic diseases, but in this case there's one with TSLP. Now remember, TSLP is one of the alarmins that is released by ILC2's innate lymphoid cell type 2, which is the innate equivalent of the Th2 cell. So something goes wrong in the epithelium. Those details are not clearly understood, but an alarm is triggered. ILC2's fire off, release TSLP, and this orchestrates a Th2 response. So it's not surprising that genetic changes around the TSLP locus or within it are associated with this condition. Calpain 14, calpain is highly expressed in the esophageal epithelium, and particularly in patients with this condition, and so again there's an association there. But the bottom line, as I mentioned earlier, is this is driven by Th2 cells themselves. So this is how it goes. TSLP is released in the way that I've outlined. This acts on dendritic cells to push them to a Th2 inducing phenotype called DC2. I don't talk about that much in the course, but suffice it to say that certain factors act on dendritic cells to make them more likely to turn a naive T cell into a Th2 cell. So those factors drive that differentiation, and as you know, Th2 cells produce IL-4, 5 and 13 predominantly, and here IL-13 seems to be central to pathogenesis by contributing to barrier dysfunction, by increasing calpain 14, by promoting type 2 inflammation. The mucosa then releases eotaxin, which as the name would suggest, attracts eosinophils. Th2 cells produce IL-5, which also attract and mature eosinophils, and then the process sort of undergoes positive feedback, inflammation begets inflammation, and so forth before a significant problem is manifest clinically. So how do you treat it? PPIs are often tried, often in high dose as the initial therapy, I guess because they're easiest, and they have some anti-inflammatory effects. Oral steroids, of course, work in most eosinophil-mediated conditions for short term, but long term the side effects are prohibitive when there are other treatments that are available. So swallowed steroids, fluticasone and budesonide, perhaps budesonide more so, are very helpful in this condition, but can be complicated by candidiasis, and the long-term side effects are certainly maybe problematic. Watch that space. But when those simple things have not worked, or the patient wants to know what definitive treatment there should be rather than relying on these types of treatments, then we go on to try logically to try and work out what the trigger was. Now, we don't have any lab tests to guide us here because T cells are difficult to study in terms of their functional characteristics within the laboratory. So it's a bit of a trial and error thing, a bit of a gamble as to what you're going to put your money on as to the foods which may be causing it. Well, I guess the most extreme would be an elemental diet, but we're not going to stay on that forever. So the usual thing is to go with a 6-fed, 6-food elimination diet, and that avoids the most common triggers, and in most cases this will bring about resolution. And once all of those 6 things have been avoided and the symptoms are better, or the histology is better, then you can reintroduce them one by one to see which of them reproduce symptoms or worsen the histology on biopsy. And many cases this is milk, many cases it's wheat, and the other ones are proportionally less frequent, but nevertheless there. So an alternative to that fairly extreme approach is a step-up diet. 2 foods are eliminated, and this is pretty successful. And if that doesn't work, go to 4 foods, adding egg and soy, and finally then add 6 foods, and you'll get closer. And after that, then I guess the search is going to be pretty difficult. But other things can be tried. And then biologics, of course, have been tried in this condition, and the only one that really is compelling is dupilumab, an antibody to the IL-4 receptor alpha. I've spoken a lot about dupilumab, and it targets both IL-4 and 13, so presumably the IL-13 is what is being blocked here. And this is shown to work for eosinophilic esophagitis in adults and adolescents, both improving the histology and of the symptoms. Other things have been tried, but without consistent clinical benefit, but nevertheless, I'm sure more will be forthcoming over the years. I've mentioned other surgical interventions if the long-term complications have already set in. Okay, so just to summarise what we've spoken about in this quick talk, eosinophilic esophagitis is a Th2-mediated inflammatory disease within the atopic spectrum relating or driven by a Th2 cellular response to foods, not an IgE one, and therefore skin testing isn't helpful. The pathogenesis is driven by IL-13 as attested by the response to dupilumab, which blocks the IL-13 receptor as well as the IL-4 receptor. And it's also driven partially by IL-5, although anti-IL-5 therapies don't seem to be as effective. The presentation clinically is very similar to reflux that doesn't typically respond to simple things. Dysphagia can occur, food impaction can also occur, and untreated, the inflammation can give rise to fibrosis, which of course has its own surgical intervention treatment. Diagnosis is on biopsy showing eosinophilic infiltration. Treatment is initially with PPIs and topical steroids, but ultimately by dietary elimination, going through those food elimination tests as I've outlined, and consideration can be given to biologics. Histological response, sometimes more reliable than symptoms, but nobody really wants to have an endoscopy every few weeks while they're on this elimination diet. Nevertheless, it is the optimal approach scientifically, or with medical science, but perhaps less so with patients. So a little bit of give and take as you work through those elimination diet processes. Okay, I hope that was useful to you. I will leave you with this nice view of the fjords in Norway and catch you for another episode soon.